have everyone here. I want to welcome you. I want to thank the Oliver Center who has allowed us to videotape. Now, if you have missed a lunch bunch in the past or want to go back and kind of refresh on what you've learned today, you can go to the lunch bunch, search for lunch bunch on the UTMB homepage, and there'll be an archive of all the past lunch bunch presentations. So a wonderful resource that we have there. And then I'd also like to thank UTMB for providing a wonderful lunch for us to sit here and enjoy the topic. Because how many people have wondered what is wrong with a vagina? And that's what gives gynecologists business, right? Well, I want to tell you that I'm so proud to introduce not only a wonderful colleague, but a friend to present today. Dr. Catherine Hansen is a gynecologist, but not only a gynecologist and just has that expertise, but we have brought to you a gynecologist that has a fellowship training in sexual health and dysfunction. So she is an expert, and she is our expert on treating sexual dysfunction and also pelvic pain. So I am so thankful to have you here. Been looking forward to this talk so much. And I also want to tell you that in addition to having Dr. Hansen, we also have physical therapists. Dr. Utsi is just so skilled at taking care of pelvic pain and discomfort. So two experts, two of my friends and colleagues that I have for you today. All right, without further ado, Dr. Hansen.
Thank you. Thank you, Dr. Muir. And so, yes, my fellowship is in sexual health, but if sex is healthy, it's not very often that I would see people. So I think it was very accurate to add sexual dysfunction, and so that's what my additional training was in beyond the OBGYN residency. And so what is wrong with my vagina? And I tried to use this title for the magazine article that was part 4 of the sexual health series in Life is Good, and I brought some of those, but they changed the title on me for that purpose. I guess this is not the way they want it written, but it's very often what I hear in the office. Someone comes in and says, "What's going on? I don't know what it is." They're befuddled, they're confused, they're not sure. And so hopefully we can answer some of those questions today because it is a very bothersome symptom. I am assistant clinical professor here at UTMB. I contract here at the Pelvic Health Center with Dr. Muir and her colleagues. And I like to disclose right away that I'm Canadian because you'll hear the out and about in my voice and you'll kind of wonder, where is she from? I'm here because of this man who is training at Nassau. And I have a couple of other companies that I contract with that I want you to know about as well. So menopause or time to pause. And so this is a model, an alteration in the medical model that Dr. Lissa Rankin, she's also OBGYN, has sort of switched streams from clinical practice. She's created this whole health Karen. And I really love this. And so I kind of use it for everything that I do now. And essentially, this area in here, oh, my little laser's not working, but this area in here where we've got sexuality, relationships, spirituality, you can see that it's a very essential part of this Karen. And so if it's not working, the whole person is not functioning properly in most cases. And this doesn't have to be a sexual relationship, but an intimate relationship or other relationships in our lives. And so those are very, very important, because on all of this teeters our physical health and our ability to heal and our ability to feel as though every day is well lived. So we're going to talk a little bit more about menopause because that's usually when the vagina starts to cause trouble, and some of the other reasons that the vagina causes trouble we'll quickly mention. And I'm really hoping to hear any questions that some of you might have. So perimenopause meets menopause, and the general trend is down and out, it seems. Everything is kind of prone to gravity. And so we have a lot of symptoms associated with those menopausal changes. And interestingly, when women, and I wish this laser was working, but, oh, wait.
It's just not working on there.
Is it working over there?
There it was.
Oh, it'll go over there, but not over there. So essentially, when the estrogen starts to fall off, women will immediately notice symptoms of hot flashes, insomnia, night sweats, those kinds of things. But the vagina is well maintained. Oh, I see. Oh, yeah. The vagina is actually well maintained till several years after those symptoms. And so that's why people don't always associate the vaginal symptoms with menopause. They come in several years after they've had maybe resolution of those menopausal symptoms, and then all of a sudden they're like, now what's wrong? It can't be menopause because that was years ago. And so they've changed the terminology on us, and I think this is just interesting to highlight. You don't have to read the whole slide, but essentially we're not calling the vulva and vaginal atrophy. We're not calling it vulvar-vaginal atrophy anymore. We're calling it genital urinary syndrome of menopause. And so there was this big task force put together, and they decided when we talk about male dysfunction, we say erectile dysfunction. There's no mention of penis in there. And now we have vaginal issues and atrophy, which means a failing or a withering away. And so they've changed the terminology from vulvar-vaginal atrophy, which I guess was offending some, to this GSM or GSUM. And it very accurately identifies that a lot of the symptoms are related to the urinary tract as well. And so we know that approximately 64 million American women are reaching menopause, and half of them, up to half of them, are going to be affected by those vulvar vaginal atrophy symptoms. And I'm going to use those two terms synonymously, but understanding that in the literature we're now calling it genital urinary syndrome of menopause, which is a bit more of a mouthful. And so we notice people are starting to have, around that time frame, or 4 to 5 years after the menopause, they're starting to have vaginal dryness and dyspareunia, which is a big word for pain with sex. And even if someone is not having sex, they're having irritation or dryness and sometimes other symptoms in the vagina that are causing them concern, all related to that lack of estrogen. And so some pictures, and there's some very graphic pictures on here, but also in the magazine recently I wrote an article that if you haven't actually looked down there, get out a mirror, have a look. It's really important. There's a lot of things that can be going on down there that you should have some idea what it looks like. And a lot of people just never ever look down there. So essentially the vulvar and vaginal areas start with very rugated or folded areas. Well, no, that's not even working. Lots of blood flow, moist and thick skin, and then as estrogen falls off, the skin loses its folds, it loses its moisture, becomes drier, starts to cause some issues, as I said, about 5 years after menopause. Here's some of the graphic pictures I told you about. In 2002, and then in 2003, a little bit later, you can start to see some thinning of the vulvar area. And even more, now it becomes very pale, and then in 2008, really very thin introitus, so that's the opening of the vagina. Things become very thin, they become very pale, there's not a lot of blood flow down there. And I will kind of go on the side and say, you know, around the time of menopause, people will come in and say, it just doesn't feel right down there. I can't feel it like I used to. Well, I try to explain that, you know, our blood flow to all of the areas of our body start to decrease as those blood vessels get older, and things like atherosclerosis, where there's hardening of the arteries. We aren't getting blood flow to a lot of areas of our body. Has anybody noticed with aging, and I put myself in the perimenopausal category, any changes in taste? Yes. Any changes in smell? Any changes in vision? I mean, I'm getting my glasses, my prescription updated very, very regularly, a lot more than I thought I would ever need. So those are our senses. Same with the vulvar area, same with the vaginal area, same with the clitoral area, which is where we get our greatest sensation. And so I try to explain to people that all of that feeling is going to change down there with age-related changes. And it's not necessarily abnormal, and it's something that we have to learn to be quite creative with, and we'll talk about that a little bit more. And so there's 3 basic changes that I want you to just sort of understand so that you have some biologic understanding of what's happening. The pH, which is the acid base in the vagina, changes. The superficial cells, which are sort of that layer, that carpet on top, and then the parabasal cells underneath. And in this area, the yellow highlighted area, is where the greatest estrogen receptors are. So therefore, as estrogen falls off, it's the area that's most greatly affected, which is why we're calling it genital urinary syndrome of menopause. And so again, this thick carpet-like area on top are the superficial cells, and it becomes much thinner. The parabasal cells thickens a little bit as estrogen falls off, and I'll show you a little diagram here. So we have that nice folded area. The superficial cells in the vagina, and this is important, I'm going to come to why in a minute, but the superficial cells of the vagina are always sloughed off. They're sloughed off just in normal life, but also with sex. And when that happens, glycogen is released from those cells. It feeds the lactobacilli, little pink tic tacs that are normally living in your vagina. And you get a secretion of lactic acid, which means that you have a normal pH in the vagina. And as all of that cycle changes, the pH starts to go up because there's not as much superficial cells sloughed off. And the reason this is most important is because the goal with any treatment in the vagina is, with any people who come in that have painful sex, the goal is not necessarily to change all of these measurable parameters that we're studying all the time. The goal is to get back to having comfortable, regular sex. If that's the symptom and sex is painful, the goal is to get back to having regular, comfortable sex. And once you're able to do that, those superficial cells will be sloughed off. This whole cycle will start to kick in again. And it really doesn't matter whether you remain on any medication at all, although you may need to, as long as you're having comfortable, regular sex. And that's part of the treatment for people who are having painful sex. For people who are not having sex but having vaginal symptoms, it's a little bit different. And so these are the basic symptoms, and this is what I see in the office. I think I'm having, I'm having vaginal discharge, I'm having irritation, I'm having burning, I'm having more bladder infections. All that's related to this vulvar vaginal atrophy or genital urinary syndrome of menopause. And so I put this slide up just to identify that there are many pathologies or things wrong down there that you need to have a look at and that you may need identified. So lichen sclerosis is very, very common. It's common in all age groups. It's even common in young girls. And it can occur in other areas of the body, and basically that's just a change in the skin. But you need to have someone look at the area, if the vagina and vulva, if it's bothering you, because it could be any one of these things, these long lists of things that could be happening that are causing those symptoms. And some of them are something you definitely don't want to go untreated. So down here we've got precancer and cancer of the vulvar areas, and really important to have someone look, and for you also to look to make sure you know what's going on down there. I find this really, really interesting. In people who have symptoms of vulvar vaginal atrophy, so they have that burning, dryness, irritation, pain with sex, they've done studies to show that they also have what they call comorbidities. They more often have visits to the doctor's office. They more often have hospitalizations. They more often have angina. They more often have osteoporosis, migraines, insomnia, and anxiety. So this is a well-done study that shows us that people who have vulvar vaginal symptoms more often have a lot of these other things that go along with not being overall healthy. And why is that? We're not exactly sure. I could postulate a few reasons, but I don't know for sure. And so the other interesting thing is that they've done a lot of studies where they've looked at patients' perception and who starts the conversation, and why are there so many people walking around having these symptoms and not talking about it in rooms like this or in support groups or to their doctor. Why is that? And also, I don't know the answer to that, but hopefully we'll come up with it, and we can postulate some reasons, and then we can start to have more open dialogue with our friends and get the topic more openly discussed so that we can get it more openly treated. But also very interesting, the dark line, the dark purple is men, and the light purple is women. And you'll see that more often the men are the male partner of a patient who has these symptoms is more often avoiding intimacy than the female herself. Over here it says they've lost libido. So men have also lost libido related to this. Finding sex painful. It's almost equal. The men and the women are finding sex painful. And that's the man having pain potentially, or perhaps thinking he has pain because his partner's having pain. Worrying that sex will be painful, the men are more worried than the women. Worrying that sex won't be satisfying, about the same. Worrying that sex won't be satisfying for themselves or their partner, that's these two lines here. And feeling less attractive. The men are also feeling less attractive related to their partner having these symptoms in the vagina. So men are deeply affected by this as well. And we know that, and this is something I just like to identify anytime I do a talk like this, is that I really feel passionate about helping people have comfortable, satisfying, healthy, safe sexual relationships. And why is that? Why is that something that I have devoted a large part of my time to? Well, it's because it comes right above on Maslow's hierarchy of needs. We've got our physiologic, our food, our shelter, our water, the things that we're so grateful for every day, security and safety, and right above that is intimate relationships and friendships. So it's part of what helps us reach our self-actualization. It's part of what makes us who we are, and it's part of what gives us the it empowers us to go out every day and be our best professional, personal selves. And so it's very important that those things are dealt with if there are issues there. And so what do? Non-hormone treatment is a really good option, and as I said, regular sexual activity that's going to promote blood flow, that's going to slough off those superficial cells, going to cause more superficial cells to grow. Water-based lubricants, there's personal lubrication that you use during sex, but for people who are not having sex or who want something when they're not having sex, there's water-based or polymucosaccharide or basically vaginal moisturizers that can be used regularly, and those are non-hormonal. Obviously, anything that increases blood flow to the vulvar vaginal area is going to be really helpful, and this includes masturbation or using vibrators, and I'm going to show you some pictures. Cleansing with water, not soap. There's all kinds of things that we call vulvar hygiene, or things that are going to protect the vagina from chemicals, from harsh bleaches on the toilet papers. A lot of times people come in and say, I have really bad symptoms at work, and a lot of times it's because of those chemical harsh toilet papers that people are using, and they've got a lot of chemicals in them that are causing irritation. And so we talked about non-hormone treatments. We talked about increasing blood flow in many, many ways. We're going to get to in greater detail this physical therapy option for sexual pain as well, and identifying that there are other issues that could be complicating things. So bowel issues will also cause trouble, as well as bladder and vulvar problems, and infections that need to be ruled out. We're not going to get into great detail in this at all, but understanding this process, and I'm suspecting that Dr. Yutzi will be talking a little bit about this as well, because once you have pain in the vaginal area, so whenever there's pain, there's going to be a fear of having sex. Why would you want to do something that's going to be painful? If there's a fear of having sex, you might end up with some relationship issues, or maybe the relationship issues lead to the fear of having sex. Then there's going to be some anxiety, and when you have pain for any reason, why wouldn't there be some anxiety around it? And then you can develop this diagnosis called vaginismus. Essentially, that's a contraction or a spasm, an involuntary spasming of the pelvic floor that's complicating this whole picture. And so I'm not going to get into great detail of that, but just know that if you have dryness and you have pain with sex and you grit your teeth and bear it through it, you may end up with other issues that can come along. Hormonal treatments are very important and very, very safe. So we know a lot, estrogen has got a really bad rap lately, but vaginal estrogen in various forms is not really systemically absorbed. And so when for example, if I were to call an oncologist of somebody who has had breast cancer and say, quality of life is really impacted here, would it be okay if, and you have to do that on an individual by individual basis, but would it be okay if we use some vaginal estrogen? estrogen? And almost always, yes, it is, because the systemic absorption is so little. And beyond creams, there are vaginal rings that you can wear to help increase estrogen to the area. There's little tiny tablets that go in the vagina that can also increase estrogen to the area. So there's multiple ways of getting estrogen back into those tissues if estrogen is a reasonable option. Watching for potential side effects of estrogen, and you need to be talking with your healthcare provider about that. And we know that local vaginal estrogen isn't just going to help with the painful sex, it's also going to help with that dryness, that irritation, preventing infections from happening, just making it a healthier environment overall. There is a pill that is focused on the vagina. So there's a pill that you can take in your mouth orally that will also put more estrogen into the vaginal vulvar area, and it focuses it in that area. So it's not like a hormone replacement therapy per se, it's focused on the vagina, and that is also an option. I find this really discouraging. I was going to say fascinating. I find it really discouraging that almost 80% of people who initiate a conversation about their sexual pain is the patient. It's a huge minority of the time is it the healthcare provider who initiates this conversation. And so this is why we need to be educating, OBGYN residents and physical therapy residents. And, basically we want healthcare providers to be aware that this is impacting quality of life and therefore impacting all kinds of things in society in general. When people are having unhappy relationships for various reasons. This is important. And also interesting is that most people are actually discussing this issue during their well exams, during their routine visits, or during a visit. So this is, I can't do the math that fast, but 90+% are actually talking about their sexual pain and their sexual concerns and libido issues and those kinds of things during a visit that isn't intended to talk about that issue. So that's important for us to know, but as patients, it's important for us to realize that a lot of times in this current healthcare system, our doctor doesn't have time to do a complete well visit or to deal with your sore throat or your ear infection, and then also deal with the sexual health issue, which is, as we've already seen, hugely complicated. So making a separate visit is very, very important. And I'm going to show just a couple of really quick, busy slides here just to let you know that all we've dealt with is this biological portion of sexual health. So the vulvar vaginal area, that it is hugely complex. And there are a lot of other issues that go into having a healthy sex life, more so than just talking about what's happening in the vagina, and all that for another talk. So when we talk about treatment, I want to go through a couple of things that you can have sort of as take-home messages. Physical arousal is very, very, very important. So again, people will say to me all the time, it doesn't feel the same. I can't feel it. I can't figure out what's going on down there. And it's really important to find a way. So just like your taste and your sense of smell and your vision and everything's changing, so is the sensation in your vulvar vaginal area. And you got to be a bit more creative. So finding a good, healthy, safe lubricant, Crisco works really well. And increasing arousal. So that may mean taking some risks, understanding that, I really love this quote I got at a retreat once. The thing about recognizing our own limitations is we get to keep them. So really, try not to have limitations. What has worked, and I say this to patients all the time, what has worked for you in your 40, 45, 50 years of marriage isn't working for you now, or you wouldn't be sitting here. Let's try something that's going to work for you now. Let's try something a little bit different. Take some risk. Gives us all something to laugh about. And I don't know if you can see the little man up in the back there getting thrown through the waves. So really important to take some risks. Lube it up. His and hers, that's great. I don't recommend the heating lubricants. You can buy lubricants that actually heat up and get hot. I don't recommend those necessarily. Some people like them, but they're not. If it's already hurting and irritated and burning down there, it's probably not a great idea. The Crisco is a really nice option. This, yes, is another option that has been identified to me by a lot of patients. It has to be shipped from the UK, but it is a really nice option that people have started to tell me about that they're ordering and enjoying.
Is it YES?
YES, yes. Yep. And this is from Brookstone.com. So, I mean, shopping at Brookstone is not that risque, and these are personal massagers. So look up personal massagers and certainly help yourself to something that's going to help you increase the sensation down there and help you increase the blood flow down there. This one is very interesting. It has a wireless range of 30 feet, which I find fascinating. I'll let you guys think about that. And foreplay, essential, essential, essential. Okay, so again, what has worked for the last 10, 20, insert number of years is not working now, or you wouldn't be coming to me for help. And so let's try something a little different. Obviously, a patient partner. And I can't tell you the number of times people would say, well, he's very patient and it's me, I'm broken, it's me. But it's never just one person, it's always a relationship. We saw the bar graphs with the man and the woman being equally affected. So this is a relationship issue, it's a relationship solution. And then this just gets back to what I was saying about modeling. So if we have healthy, long-term, very vibrant relationships, all the people we're role modeling to are going to see that. Our children, our grandchildren, all of the people are going to see that relationship is functioning well, and that is going to carry not just ourselves into the future, but it's going to carry our entire family structure into society as a whole. And so a couple of things I just want to point out. This is my website. There's a sign up for wellness, so I send out these kinds of little articles on these kinds of topics and other topics all the time. You're welcome to go there and sign up. I have brought a couple Life is Good magazines, which have my part 5 of a sexual health series, and also on my website you'll find part 1, 2, 3, and 4, as well as a 5-part menopause series. So just a lot of education that you can use to help yourself and to figure out where you need a healthcare provider and where you can find the help that you need. I'm holding a wellness retreat. There are no pharmaceutical or industry affiliations with this, so this is something you can come to and just learn. We're going to be talking about just living your best life, all the various ways you can get yourself as healthy as you can possibly be. And I have Ms. Sue Geiger here today, who can help us register if you would like to register today, or you can give your information to her and she can help get you registered. It's in a beautiful place in Dickinson. If any questions about any of that, please let me know, and I'm going to hand over to Dr. Yutzi.
We're going to take some questions right quick.
Yeah, so I'll take questions, I guess, before I take the mic off. Brandon says I should do that before I take the mic off. Yeah.
So I was very interested when you said about the toilet paper, because I've noticed that problem, but I have no idea what brand would be non-chemical.
So you can go and look for basically a natural brand that it can say unbleached. I will generally, and I don't know the accuracy because I haven't read studies on this, but I'll generally look for things that are safe for septic systems because they're not going to have a lot of harsh chemicals in them or bleaches in them if it says safe for septic systems. And everything white, so you don't want anything with dyes or, yeah. And definitely, I've even educated some people to take their own roll of toilet paper to work and keep it in their purse. Sometimes that'll make a difference.
You just see me on the airplane now.
Yes. Anybody else?
I would just like to add something because I was at her January meeting and I learned 2 very important things that no one had ever told me, and that is she taught me about the big P, which is you drink a whole thing of water before you have sex, maybe 15, 20 minutes or whatever, where afterwards you will have this big P, which will keep you from getting a UTI. And another thing I learned from somebody who attended was she takes an Alka-Seltzer after sex, which is alkaline, and it keeps your body from developing the UTI because all of a sudden you're putting an alkaline ingredient into your system. Those 2 things have helped me so much, and I wanted to share that with any of you who might be having problems.
So just an Alka-Seltzer and a cup of water and drink.
That's it.
Sue's always so good at sharing, and and helps me to kind of do a lot of community outreach. And there are, every single day in clinic, I have patients coming in that say, I want other people to know what I'm dealing with so that they know that they're not alone. And I think that that's just, very important for us to start openly talking about things that we aren't sure about. It's time to open that conversation.
And then having sexual relationships regularly. What's the best thing to do if you want to have sex into your 80s? Because I know people, women who say, I'm not interested anymore, and they're just 60, and I look at them like I'm flabbergasted. How can that be? And I don't want to be that person. I want a sexual future until I have trouble walking or something. I don't know.
Good.
So,
Or that makes it hard for you to walk.
nobody really tells us how you do that.
Well, I think the key, go ahead, do you want to answer her?
I have experience.
Yay.
And I discovered in my 60s, I had the best sex ever.
That is great to hear.
Yes, absolutely.
So what is your tip? What is your advice? What is your take-home message?
Well,
How
I
do
was
we all
very
do that?
active. I played a lot of tennis, and I was a walker. Now I'm learning to drink water, and I'm glad you said that about water, the alcohol.
Right.
So physically active, keep your body physically active. It's not only going to help you to have the stamina to continue with a happy life and sex life, but also keep blood flow going to all the areas of your body. So if you're healthy and your cholesterol's in check and your blood pressure's in check, there's a better chance that everything down there is going to be functioning better as well. And my 2 cents would be that you really need to be creative. If it means buying a book or buying a video or finding a way to open new conversations with your partner, there has to be some creativity and something to look forward to. And a lot of times people will get bored, and those are the ones that say, I'm not interested.
Usually more. Okay.
I can talk to you after this is over about the Yes products. They're fantastic
I never heard of it before.
because you can only get them from the United Kingdom. It takes about 3 weeks for them to come, but I found out about those at her January workshop because another woman had brought them to show us. And I'm like, I've tried everything, nothing's working, I'll order these, and it's fantastic.
Are those vaginal moisturizers? I didn't know the difference between that and a lubricant, quite honestly.
So a vaginal moisturizer would be something that you put in regularly, whether you're having sex or not, just to keep the vagina environment healthy. Personal lubricant or a lubrication that we would use would be during intercourse. So put lots of it on and reapply it regularly during the sex act, even before penetration. So lots of it all over the place. But the Yes product has both of those, personal lubricant and moisturizers, just a couple of different options.
All right, so this is a tough act to follow. She was great and had great information. I am Carolyn Utze. I am Associate Professor and Chair of the Physical Therapy Department at UTMB, but I have the great privilege of working here with our team at the Pelvic Health Clinic on Mondays. And then I have other physical therapists, Carla's back here, and then a student physical therapist that's with us today. So this is exciting for me to be able to kind of explain to you what the role in physical therapy is all about, especially in treating areas of pain, painful intercourse, or vaginismus. So I'm glad to be here with you today. Talk with me just a little bit. What do you know about physical therapy? Do you know what one of the first questions somebody says to me, or comments that somebody says to me when they come to see me, a physical therapist, after seeing Dr. Hansen or seeing Dr. Muir? What can physical therapy do for me? I didn't know that they dealt with those kinds of things. So how many of y'all have had experience with physical therapy? Mm-hmm. So what are your thoughts? What do we do?
Get you back to center.
That's a good way of putting it, getting us back to center. Anything else that you can think of? You've experienced it? What's your perception about what we can do with painful vaginas?
No idea.
No idea. Well, good. I'm glad I can be here and help you today. Well, we use research and professional expertise to assist individuals to get back in motion or get back in center. So that's exactly what we do. We do need a physician referral. And in Texas right now, that's the law. You could come to us for a physical therapy evaluation and we could evaluate, but we would always refer back to a physician in order to get the actual permission or referral for intervention. We're working on some different areas for that to look more at direct access, but it is a team approach that we use in order to make sure that we're doing the best for you, the patient or the client. The physician determines the medical diagnosis. We as physical therapists determine the physical therapy diagnosis. And we look at muscle function, we look at physical limitations and functional limitations, among a few things, as far as the evaluation is concerned. But we remain in communication, and it's always a great privilege to be able to just go down the hall and talk to Dr. Muir about a patient that we might have, or Dr. Hansen by our medical records communication. And I always enjoy getting, well, I enjoy getting Dr. Muir's patients too, but I enjoy getting Dr. Hansen's patients because I know we're really going to have a challenge and we're going to really have to work hard at getting individuals back into motion. And think about, I'll let y'all think about the motion we're talking about. So here's kind of, you know, it's that first visit. I can't say that my visit to my gynecologist every year is my favorite doctor visit. I'm a very modest person, and I think, oh, I've got that exam again. So, you know, when you come to a physical therapist, what can you expect? Well, we're going to do an evaluation of your condition, looking at your history. So that history is what got you here in the first place? What's going on? What's your current condition? So the physical exam may actually go into your general movement. I typically watch somebody as they walk into my office. How are they moving? Are they stiff? Are they tight? What's their posture look like? Do they look like they're in pain? What's going on with them? I check flexibility and strength to see what's going on there. Now, all of us know what the strength of a bicep muscle is, right? You can pump the iron. Do you ever think that you've got strength in those pelvic floor muscles? That they actually function and have a role? So we've checked for flexibility and testing not only in general, but also specifically in the pelvic floor. And then we do other special tests as well. So stand up. Stand up. I want you to pick a partner, get someone close by, just to look by. Now, what you're going to do is keep your feet just a little bit apart so that you're standing comfortably like you normally stand, and just stand there. Now, one of you go to the side and take a look at how that person is standing from a side view. A side view. Where's the head? Where are the shoulders? Where are the hips? Where are the ankles? Okay, now switch. All right, what'd you notice? Okay, sit back down now. So here are some typical postures. This is what we would consider ideal. The ear is in alignment with the shoulders, in alignment with the hips, in alignment with the knees, and all the way down to the ankles. This is a military stance, at attention. What does this stance look like to you? I'm just hanging on my ligaments. I'm being real lazy and real lax. I'm dependent on everything else except for my muscles to hold me in a good position. And then this position here, what do you think about this one?
She's down in the collapse.
Down in the dumps, That's sort of the protective mechanism that we often see with somebody in pain because they're guarded, they're pulling things in. Have you ever heard the term turn tail and run? So it's that fear of avoidance of pain, fear of possibly having pain. So the typical posture is like this. Now, do muscles function very well like this? So stand up again. All right, everybody slump. Now raise your arm up. All right, now stand tall. Now raise your arm up. Which was easier? Standing tall. Okay, so sit back down. So when you look at a posture, one of the things we look at postures is how is a person standing? And is this going to tell me something about their flexibility? Is it going to tell me something about their strength? Is it going to tell me something about what they're feeling inside because of the way that they're walking or looking? So which one do you think we want to get back to? That's right. This one right over here. And so that's part of what we look at. And so when we look at flexibility, I would ask you to bend forward, I would ask you to bend back, side, go through all the motions, because that's going to tell me not only do I expect that there's going to be something going on down here with maybe some tightness, but what else is being affected because of that tightness, because of that muscle spasm that's going on. So I look at range of motion. You just did one range of motion. You just did this. Now, how do you think I test range of motion in the pelvic floor muscles? Does it make a joint move? Do the pelvic floor muscles make a joint move? No. The purpose of the pelvic floor muscles are actually for a lot of things, but support is one. So it's made up of a sling. So when you stand up straight, your pelvic floor muscles are kicking in. They're working for you to help with your posture, and they're working for you. When I test range of motion, I test how much flexibility does that muscle have. Can it elongate? Can it shorten? I also do muscle testing, neural tension testing, trunk mobility. So I do a lot of testing just to determine what's going on here before I ever get here. Now, some of the special tests and measures, one of the first things, if I have someone who's coming to me with pelvic pain as far as in the vagina, the first thing I'm going to test is, well, let me back up just a little bit. First thing that I do is explain to you the test, because I'm going to gain your trust before I ever try to really get real personal with this. It will be a similar examination to what you get with your OB-GYN or Dr. Hansen when you go see her, but it's going to be a little bit different because I'm looking for different things than possibly what your OB-GYN or your urogynecologist would look at. So I would explain a little bit about the anatomy here. I talk to you about the muscles that make up the pelvic floor muscles, that make up your sling to help support. Besides being supportive, these muscles also help to keep from voiding when you're not supposed to be voiding. So it helps to keep the urine in, helps to keep the bowel movement in. But it also requires relaxation, not only to let that urine and let the bowel movement out, but also to have more comfortable sexual encounters. So the pelvic floor muscles are also responsible for pleasurable sex. So support, keeping things in that are supposed to come in, relaxing so things can go out, and then also with your experiences, sexual experiences. So tone is a common problem with individuals with pelvic pain or with pain in the vagina. And I will talk to my patient about the fact that first of all, I'm going to touch. So I'll test these areas here just to see if there's pain in those muscles, which can spill over from the painful experience in the vagina. I will then check sensation to see if everything is intact. And before I do anything else, I will ask you to do a few motions for me. So sit in your chair, get on the edge of your chair. I just want you to experience this. Do you feel the two bones you're sitting on? Okay, those are your ischial tuberosities. Those are your sit-down bones. Do you feel what's in between those sit-down bones? Those muscles? All right. Are those muscles up high? Or are they sitting and resting on the chair with you? Can you tell?
I could tell. How do you tell?
Okay, so slump. Slump back. So roll your pelvis backwards, like you're sitting at your desk after a long day of sitting. So you're slumped. All right, now sit tall. Did you feel those muscles come up between your legs? Okay, that's where the pelvic floor muscles are. Sometimes I get patients in this position just to get an awareness of where those pelvic floor muscles are and how they're supposed to be working. So sit there. So where are they right now? Are they sitting on the chair or are they above the chair? Above the chair because you're sitting tall. All right, now I want you to squeeze up and in like you're trying to pull them up towards your belly button. Can you squeeze up and in? All right, now let them go. So can you tell where those pelvic floor muscles are? So while you can relax again. One thing that I will look at is I'll ask the person to squeeze up and in. And so I look to see if that those pelvic floor muscles are coming in. I ask someone to cough. Again, if they're coughing, I want them to hold that urine in and not leak, so I see if those muscles go in. And then I ask them to bear down like they're trying to have a bowel movement, and I want to see if those muscles are bulging out. Typically, an individual who has pain in this area is not going to do much bulging because they're going to be tight and tense and they're going to be holding things up. So I look on the outside before I ever go to the inside. Once I go to the inside, I talk to the person about the fact that I'm going to use just one finger that's well lubricated with a glove on, and I'm going to test for muscle strength. I'm going to test for the tone to see what that tone feels like. Typically with somebody with pain, it's going to be tight. There's going to be a tight feeling if they let me do it in the first place. And then I'm also going to check to see what their endurance is like of those muscles and coordination. So I can see if those muscles are functioning like they should or if there are other underlying problems because of the primary problem of pain. So I'll look at all of these areas and I do give options because some individuals who are already painful, they don't want anybody to mess with that area. They want you to stay away, stay clear, and as soon as you get close, they tighten up and it gets worse. So another option is to use biofeedback, and I'll get into that just a little bit. So I can determine from biofeedback that's external, little electrodes on the outside, that I can use to help see what the muscles are doing. So through all that evaluation and assessment, I determine what the problems are. Where is it coming from? What can we work on as a physical therapist to make sure that we are managing pain, that we're being able to help you with the areas of dysfunction that we found, and see what we can do to bring you back to a participation and more comfortable sexual experience. So Dr. Hansen spoke a little bit about the pain cycle a while ago. One of the things that we do with our assessment is a pain scale. And we ask specific questions, not like what makes it better, what makes it worse, when is the best time of the day for you, what really activities aggravate it the most. So we get as much information about that pain as possible. But that's not what we're necessarily going to dwell on when we're in therapy, because we want to manage the pain, not let the pain manage us. So we do really work on that aspect of it as well. So here's just some physical therapy interventions that we can do to help with the pain, to help with some of the problems. All right, so what I'd like for you to do is sit in your chair comfortably with your arms resting on the chair. And this part of it is going to be, I'm going to show you some relaxation techniques. Is this the light for here? Nope. That's a little better. All right, I want you just to sit back in your chair in a relaxed position. And there's several ways we can accomplish this, several different techniques of promoting relaxation. If we can get you to relax and learn what it feels like to relax, then in the sexual encounter, after we've worked through a lot of other things here, it may come more naturally to you to be able to relax during that experience as well, which will help to decrease the tone in the pelvic floor muscles. So with you sitting there, I want you to think about a pleasant view, whether it's a beach or a meadow, a mountain. You're going to think about that and think about how pleasant it is to be in that area. I want you to think about where you feel the tension right now. Is it in your shoulders? For many people who have pelvic pain, it's in the pelvis area. That's where they carry their stress, as opposed to carrying it within the shoulder area. So I want you to think about where you're feeling that stress, where you're feeling that tension. And then I'm going to walk you through a practice session of learning how to relax. So I'm going to walk you through tightening everything up from the toes all the way up to your head, and then letting everything relax all the way back down to your toes. So follow my directions here. I want you to squeeze your toes, squeeze your ankles, squeeze your calves, really tighten those knees, tighten the pelvic floor, tighten the pelvis, Tighten the trunk, get it all the way up to your shoulders, tighten your elbows, tighten your wrist, really squeeze those fingers, tighten your neck. Now all the way up to the top of your head, really squeeze that face together. All right? Now you're going to let go at the top of your head. Let go of your face muscles. Let your neck go. Your shoulders, elbows, all the way out to your fingertips. Let the tension release from your trunk, from your pelvis, your thighs, knees, all the way through your calves, all the way out through your toes. Now I want you to breathe in through your nose and out through your mouth. In through your nose, out through your mouth. Okay? Now open your eyes. What's the sensation right now? Is there a difference than when we started? Can you feel that that's, I'm sorry?
Very relaxed.
Very relaxed, good. And that's what you need to feel when life gets stressful during the day. Now, did I have you laying down on a bed to do that? No. Might have had you fall asleep if you did. But you could do this at any time. It doesn't have to be just when you're doing your exercises. When you feel that tension rise up in you, that's something that you can work on. So we work on relaxation techniques. We work on breathing techniques. Breathing techniques, if you're a chest breather, you're holding everything up here. Everything up tight, so you're pulling everything up tight. So you want to think about being a belly breather to get that relaxation and the relaxation in the pelvic area as well. And then we transition individuals into daily activities. How can you put this into your daily routine? When is it that you feel stress? Individuals with pelvic pain typically feel stress when they're about to encounter a sexual encounter, or even inserting a tampon, or going to the doctor to have a physical exam. So those are things that you can help to use for relaxation. So relaxation are very important techniques. We can use biofeedback, and I know we're running short on time. We may start out doing biofeedback here in the clinic and send you home with your own unit. We can do electrical stimulation will help to fatigue those muscles that are in spasm to help them to relax until you can learn to relax them yourself. So the goal is to teach you how to let those muscles go instead of allowing them to control you by tightening up. And it's not a short process. It took a long time to get you to Dr. Hansen. It'll take a while to work through some of these things. We also do a lot of manual therapies. Whether it's soft tissue massage, if it's trigger point therapy, we might use a dilator also to teach our patients how to do this at home. Dr. Hansen has a great protocol that she uses, and I often use with my patients, except for the ones that say, I can't put my finger there. And so we go to a dilator instead, and sometimes we even go to a vibrating dilator. I do have handouts on where to get these so that you can go to sites that are nice sites to go to, but there might be other sites that, I don't know, haven't checked them out. And then massage and desensitization. A lot of times you get the pain in the area and it's so sensitive that you just can't bear anything touching it. And so part of it is you being in control, you taking control, and you learning how to desensitize that area so it becomes more comfortable for you. Everything that we go through is part of self-regulation, self-management, helping you stay in control so that you can kind of gear how far you want to go with your treatment, how slow you want to go with your treatment, when you add your partner as part of the treatment. So just a little simple stretching exercise. Do you remember when you could? Well, some of the stretching is stretching to the perineum. So we may teach you some of these stretching exercises, maybe get you there. Now, I can guarantee that I will never be there. I'm past that. But boy, it looks good, doesn't it? Doesn't it look like it would just feel really good to stretch like that? So we work on stretching, we work on coordination, endurance, and strengthening, and we do this all in timing, because if I took a tight muscle and wanted to strengthen it because it wasn't working properly, I'm not going to get anywhere. So I've got to get that relaxation of the muscles first, and then we start adding the exercises to help gain control of those muscles again. A lot of education. Prevention, Dr. Hansen talked about a little bit of prevention today, and believe it or not, I talk about those same things with my patients. Self-management or self-regulation, to teach you activities that are going to help you eventually not need us anymore, where you will learn to help to manage your symptoms, recognize your symptoms, and do something about them before they get manifested again. Talk about the purpose of the interventions, healthy nutrition, hydration, aerobic exercise, and relaxation. These are all important components to getting better and staying healthy. And it does take a team to work on many of these issues. And it's not just the physical therapist, it's not just your physician. There are those counselors, there are those social workers, there's nursing, nutrition, so many others that could be involved in this to really look at the person as a whole person to manage their pain.
UTMB Health, working together to work wonders.